And I am so
Sorry, just one
okay.
moment, please. I'm sorry, I was doing some computer work here. That's why I paused. But yes, thank you for being ready, Dr. Rosenfeld. I appreciate it. So we're going to be taking attendance by the standard format this morning. At 8:10, we'll be looking at the participants list. And if your name shows up clearly, then you'll get full credit for attendance with the department. Also, the cloud CME code for attendings will be distributed by the email system. All right, so there you go, Dr. Rosenfeld. Now you can start. Thank you so much.
Good morning, everyone. I am so excited to introduce Dr. Alfred Abuhamad as our Grand Round speaker today. Dr. Abuhamad attended the American University of Beirut for medical school and completed his residency and fellowship at the University of Miami and Yale. He has published nearly 200 peer-reviewed articles and has written numerous book chapters. He is the current president, provost, and dean at Eastern Virginia Medical School and won the Society for Maternal Fetal Medicine's 2023 Lifetime Achievement Award. His contributions to ultrasound and fetal diagnosis have shaped what we do in our ultrasound unit every day. He is remarkably generous in sharing his knowledge, including writing a free access book titled Ultrasound in Obstetrics and Gynecology, A Practical Approach, which has been downloaded more than 92,000 times. Every year, he takes 3 days out of his schedule to teach fellows from all over the country at the GoHo Foundation MFM Fellows Ultrasound course. Dr. Abuhamad's teachings has been fundamental to me, and I think we will all look at fetal growth restriction in a new light after this talk today. Please join me in welcoming our distinguished Grand Round speaker today, Dr. Abuhamad.
Good morning, everybody. Thank you, Emily, for this presentation. I'm honored indeed to be participating with you this morning on Grand Rounds. I'm going to share with you some information on fetal growth restriction to provide some evidence behind the recent guidelines from the Society for Maternal Fetal Medicine, and also to kind of provide some evidence behind some of the decisions that have been made. So I want to disclose that I'm on the advisory board of SonoSim, TRICE, and Pulse and More. So there are two major publications that came out in AJOG that provide some evidence to try to counter some of the recommendations that were provided in the document in the Society for Maternal Fetal Medicine. And I will try to provide some evidence to really support the recommendations that were performed. So I'll review the highlights of the SMFM guidelines fairly quickly, and I'll provide evidence for the decisions that were made, and hopefully we'll have some time for discussion at the end. First, for terminology, we chose to stay with the ACOG practice bulletin that defined fetal growth restriction as sonographically estimated fetal weight for gestational age, so your ultrasound prenatally, and the term SGA as the actual birth weight for gestational age postnatally. This is a fairly big controversy because in Europe and the ISWA guidelines use the term SGA for your estimated fetal weight less than a threshold, the 10th percentile, and then fetal growth restriction if there are additional findings such as severe growth restriction or abnormalities in Doppler. We did not want to confuse what ACOG had proposed before, and we stayed with the same recommendations. We also recommended the use of the population reference headlock, such as headlock norms for determining the fetal weight percentile. I don't think that's that controversial. We recommended the definition to be sonographic estimated fetal weight less than the 10th percentile, and we added the abdominal circumference less than the 10th percentile from the prior SMFM guidelines. And I'm not going to go through this per se. There's a lot of evidence to support this. We defined severe fetal growth restriction as sonographic estimated fetal weight less than the 3rd percentile, and we subclassified fetal growth restriction early if the diagnosis is made before 32 weeks, and late if the diagnosis is made at or greater than 32 weeks gestation. We recommended that the umbilical artery Doppler be the essential component for fetal surveillance and fetal growth restriction. We did not certainly recommend to use the umbilical artery as a screening tool in low-risk pregnancies. We recommended to use either of the three indices to quantify the waveforms. PI is most commonly used in Europe, but we added RI and SD ratio as they are commonly used in the United States. And we defined abnormal at the level of the greater than the 95th percentile for gestational age, or the presence of absence or reverse end diastolic velocity in the umbilical artery. If the umbilical artery Doppler is normal, we recommend it to repeat it initially in 1 to 2 weeks and then at increasing intervals if it stays normal. This is coming from some evidence that the Doppler, umbilical artery Doppler may deteriorate early after diagnosis. I don't think that is true based on some evidence that we have not published yet, but certainly this is the evidence that existed at the time. When you have decreased end diastolic velocity, so your Doppler indices are abnormal, or in the presence of severe fetal growth restriction defined less than the 3rd percentile, repeat the Dopplers weekly. When you have absent end diastolic velocity twice weekly and reversed, certainly you need testing at least once to twice daily, meaning that probably when you get to that level, those pregnancies need to be admitted, given steroids, magnesium, and monitored very carefully in patient. We recommended against the use of the MCA Doppler in clinical management of early or late fetal growth restriction, quite controversial topic. And we recommended not to incorporate the ductus venosus Doppler as part of a national guidelines for clinical management of fetal growth restriction in the United States. Also quite controversial. We also provided some caution about the usefulness of the biophysical profile in fetal surveillance, especially as it relates to the early severe fetal growth restriction. This really does not apply to the fetal growth restriction beyond 32 weeks, but this is, and I'll show you the evidence, there's some caution about using the biophysical profile, for the 25, 26, 27-week pregnancies that you are monitoring carefully in the hospital. Delivery for maternal indications, hypertension, which will complicate a significant proportion of severe early fetal growth restriction, the presence of spontaneous repetitive late decelerations, any associated comorbidities, and at 38 to 39 weeks, if the estimated fetal weight is between the 3rd and the 9th percentile, 37 weeks if you have abnormal umbilical artery Doppler, but still with forward flow, or you have severe fetal growth restriction, and then the window of 33 to 34 weeks if you have absent end diastolic velocity, and 30 to 32 weeks for reversed end diastolic velocity in the umbilical artery. There's some controversy what to do. In our lab, we recommend cesarean delivery for all those with reversed end diastolic velocity, and probably with a significant proportion of those with absent end diastolic velocity. But there is some potential room for contraction stress test and then assessing whether the patient can tolerate labor. In my experience, most absent end diastolic velocity will show during labor some non-reassuring fetal tracing that would warrant delivery by cesarean section then. These are the most controversial points from the guidelines, certainly the diagnosis, the role of the MCA and ductus venosus Doppler, and biophysical profile. And I'll try to provide some evidence to support these recommendations. So first, if you look at comparing the Hadlock formula with this is the intergrowth formula from that was developed by the team in Oxford. It's an international formula. You could see in a large population in France that the Hadlock formula here, in looking at the mean birth weight, you see that the Hadlock formula predicted better the mean birth weight at all gestational ages when compared to the intergrowth formula. And that's why they concluded that it was more accurate for fetuses delivered between 22 to 34 weeks. And then if you look at comparing the Hadlock formula with the NICHD formula, you see whether you're looking to predict severe neonatal morbidity or the presence of SGA at birth, you will see that the Hadlock formula in red here predicted better than the NICHD formula, for these two outcome parameters. And certainly, this paper recommended that the Hadlock appears to be superior to the NICHD formula that was developed recently. And if you look at comparing, this is from Kipros's lab, comparing various formulas with the prediction of small for gestational age after birth, you see that the Hadlock formula consistently performed better than other formulas when compared. So it appears that the Hadlock formula performs better than the existing formula, and that's why we recommended to use population references in your ultrasound formulas for prediction of fetal growth restriction. Then we added the abdominal circumference to the sonographic estimate fetal weight below the 10th percentile. If you look, and the rationale for sticking with the 10th percentile threshold or below is that if you look at this large study that was done from the team in Oregon, you will see that for every gestational age, comparing the estimated fetal weight between the 5th and the 10th percentile versus those greater than the 10th percentile, you'll see that's about 2 to 3-fold increase in the risk of IOFT. And that is a similar threshold for fetal surveillance that we commonly use in gestational diabetics, hypertension, SLE, and other comorbidities in pregnancies. And if you look at the neurodevelopmental delay in small babies at term, this is a systematic review that included 28 studies looking at SGA fetus at birth. So these are small for gestation age compared to a large cohort of adequately grown newborns. You'll see that the neurodevelopmental scores, these are without fetal growth restriction. So these are the definition of SGA that is used in Europe. You see that their scores are about 1/3 lower than the scores of the controls. And if you look at the presence of placental pathology that correlates with underperfusion, again, these are 126 SGA fetuses with normal umbilical artery Doppler that delivered at greater than 34 weeks. When they look at the histologic findings of placental underperfusion in a well-defined manner, they found that they're present in about 67% of what we call SGA placentas. And that was associated with a higher incidence of emergency cesarean section, neonatal metabolic acidosis, and increased composite neonatal morbidity. And if you, and ironically, when you look at in this population, those that have these placental underperfusion pathology compared to those that didn't, that neither the umbilical artery MCA or the ratios of both predicted the presence of those. And this is with late onset fetal growth restriction. And then when you look at the presence of placental aging on pathology and comparing SGA with controls as it relates to fetal growth restriction, you see that irrespective of the marker of placental aging that you use, you see that there is significant presence of placental aging as compared to control in those SGA fetuses, meaning they're newborns, they're small at birth, but having normal Dopplers as compared to fetal growth restriction. So this really supports a common pathway and challenges the concept of SGA fetuses being just constitutionally small. So because of all this evidence, we decided to keep the definition at less than the 10th percentile as an entry criteria for fetal growth restriction. And if you look at the existing national guidelines now in the UK, New Zealand, Canada, and the United States, the 10th percentile is used as a threshold to define fetal growth restriction in those settings. So that's why we kept that definition, given the association with the outcome that I described and the pathologic association with placental disease. Now, if you look at one of the controversy that was discussed extensively in the literature recently is why not adopt the Delphi consensus that was published in 2016, and this is the reference for that, for diagnosing fetal growth restriction. And the Delphi consensus For early fetal growth, so you have the same definitions for early or late. For early fetal growth restriction, if you have the AC or estimated fetal weight less than the third, that's sufficient by itself. Or if you have absent end diastolic velocity in the umbilical arteries, that's sufficient. But if you don't, you need estimated fetal weight less than the 10th percentile, plus either an abnormal uterine artery Doppler or an abnormal umbilical artery Doppler. And if you're talking about late fetal growth restriction at or greater than 32 weeks, this definition alone is sufficient, AC or estimated fetal weight less than a third, or you need at least two of the three following, either an estimated less than 10th plus your growth has lagged 2 quartiles, meaning you had an estimated fetal weight at 25 weeks of 75th percentile for that gestation age. And then when you got to 34 weeks, now it is 20th percentile. Or you have an abnormal CPR ratio or an abnormal uterine artery Doppler. So if you look at the Delphi definition, that necessitates that we do uterine artery Doppler on all our pregnancies with fetal growth restriction, MCA Doppler, and repeat an ultrasound in the third trimester. I'll show you some of the evidence that contradicts some of those definitions and also why we decided not to adopt this definition. So when you look at the Delphi definition, the Delphi methodology, if for those who do not know, is you send out surveys to experts in the field, and then through 2 or 3 or 4 iterative processes, you end up with a consensus from the experts on what the definition should be. Typically, it's a methodology that is used to address topics that cannot be answered by clinical research. The fetal growth restriction research is evolving, and I think using the Delphi methodology has the risk of introducing definitions that is biased by the opinion of the experts and heavily weighted by the experts that you choose, rather than having a scientific vigor into the definition itself. When you choose a diagnostic test in medicine, it is really important that this test predicts the disease you're looking for. And in this situation, fetal growth restriction or SGA at birth. So for instance, when you look at growth velocity, that is part of the Delphi definition for late fetal growth restriction, and this study is from Nikolaidis' group, when they compared the growth velocity between 20 and 36 weeks, you would see that the growth velocity predicted less accurately the presence of an SGA less than the 10th percentile or an SGA less than the 3rd percentile when compared to just an estimated fetal weight at 36 weeks. So the growth velocity did not really perform in predicting the presence of SGA as equal to just doing an ultrasound at 36 weeks. And if you compare the growth velocity between 32 and 36 weeks, again, you see looking at even adverse perinatal outcome is not improved by adding this growth velocity over just the classic maternal factors. So there's evidence, and this is a systematic review that shows that looking at the longitudinal assessment, this is for the AC velocity, even in predicting SGA or late fetal growth restriction, that the longitudinal assessment of fetal growth from 2nd to 3rd trimester had a low predictive capacity for both SGA and late fetal growth restriction in low-risk singleton pregnancy, just compared with a cross-sectional growth evaluation. So just following up with an ultrasound, 36 weeks seems to be the most optimum for late fetal growth restriction, will perform better than relying on the growth velocity between 2 ultrasounds. Now, let me move to the clinical management of fetal growth restriction, because this is where a lot of the controversy exists. It is really important when you write guidelines for a society to be implemented in the US, for instance, that major management decisions, and in fetal growth restriction really is delivery triggers, right? I'm using a test that I'm going to decide whether to deliver this pregnancy or not, should be based on solid evidence that actually impacts outcome rather than the presence of mere associations. So having just the mere association between a test and an outcome is not enough to be included in a clinical guidelines. So when you look at high-risk pregnancy and you have a test that is included for a delivery trigger, not only it should predict this outcome, but certainly there should be solid evidence that if you deliver pregnancy based on this test, that the outcome is improved compared to the controls. Mere associations are not enough to impact management. So for instance, when you look at the brain sparing reflex, which is a very powerful test that is associated with the presence of fetal growth restriction, it is physiologically tied to fetal growth restriction. I'm going to show you that the evidence for delivery triggers that improves outcome when you decide to deliver a pregnancy, whether in the early or late fetal growth restriction, is lacking today, and we need more data before we make this link. So we decided against the use of MCA Doppler in clinical management of early or late fetal growth restriction. Why did we make this decision? This is a meta-analysis of 35 studies testing close to more than 4,000 fetuses, that looking at the MCA Doppler in prediction of perinatal well-being, and showed that it has very limited positive predicted accuracy of perinatal mortality. And if you look at the truffle trial that I will introduce when we talk about ductus venosus, when they went back and analyzed the value of MCA Doppler in this population of early fetal growth restriction, they showed that the MCA Doppler did not add useful information for clinical management in this cohort. Despite this solid evidence on the lack of important decision-making with the MCA Doppler, lack of important, impacting outcome, the ISWA guidelines still recommended MCA as part of the multimodality assessment and with a grade A, which I think the evidence is lacking with regards to its usefulness as a delivery trigger as part of your testing in fetal growth restriction. So how about the role of MCA Doppler in late fetal growth restriction? This is a bit more controversial. This is an important study by Dr. Stampaglia from Italy that was done in preparation of the Truffle 2 trial that started about a year ago in Europe. So what they did, they looked prospective multi-center observational study in late preterm singleton with fetal growth restriction. So this is AC less than the 10th percentile and abnormal Doppler at or greater than 32 weeks. And they explored the association between fetal Doppler, umbilical artery MCA at outcome, and they used the reverse ratio, the UCR ratio, because it seems that the UCR ratio has more specificity than the CPR ratio in that aspect. So if you look at what they found in this study, that after they adjusted for confounders, the association between the UCR and composite adverse outcome remained significant, but very, very close to the non-significance line, although gestational age at delivery and birth weight Z-scores had a stronger association. And they concluded that whether cerebral redistribution is a marker describing the severity of fetal growth restriction or an independent risk factor for adverse outcome remains unclear. Whether it is useful for clinical management can only be answered in a randomized trial. And that's really where the Truffle 2 trial is designed to make delivery trigger decisions in the third trimester in late fetal growth restriction based on an abnormal UCR or a CPR ratio, and really looking into neonatal outcome and seeing that if you make this decision, whether you're actually improving neonatal outcome in that setting. This is another study looking at a systematic review of the role of CPR and MCA Doppler in adverse perinatal outcome. And again, the same conclusion. Clinical trials are needed to evaluate the effectiveness of the CPR for guiding clinical management in specific subgroups. Only when such studies show a difference in outcome could one conclude that the CPR is of additional value to umbilical artery Doppler alone. So if you look at the MCA Doppler in late fetal growth restriction, there is a weak association between cerebral Doppler and pregnancy outcome in late fetal growth restriction, as demonstrated in the large study by Dr. Stampaglia. However, there's no evidence currently that incorporating cerebral Doppler in clinical management of late fetal growth restriction actually improves outcome. and the decision to do so should await results of randomized trial. And that's the rationale why we did not include MCA Doppler in late fetal growth restriction in the guidelines. We're awaiting to see the results of the Truffle study, Truffle 2 study, and when the study is out, we will reevaluate this decision. However, the ISWA guidelines included MCA PI, CPR, and UCR as part of the testing assessment in late fetal growth restriction. We recommended not to incorporate the ductus venosus Doppler, and I got most hate mail regarding that from my European friends. And let me provide some of the evidence behind our decision. This is the Truffle study, that really the only randomized trial looking at incorporating ductus venosus in clinical management. It took a long time to do. It involved multiple centers in Europe and the United States, and they looked at the 2-year neurodevelopmental outcomes in infants. This is early fetal growth restriction, less than 32 weeks. What they found in this study is when they corrected for prematurity, that the pregnancies that were delivered based on ductus venosus abnormalities, where you have absent or reversed A wave of the ductus venosus, had less neurodevelopmental abnormalities corrected at age 2. So in the absence, and they concluded that in the absence of pathologically low short-term variability, delivery should be undertaken for absent or reversed ductus venosus A wave. Now, if you look closely at the ductus venosus in this study, the Truffle trial compared the ductus venosus, either abnormal PI at the 95th percentile or absent or reversed A wave, to computerized short-term variability. You cannot extrapolate the results of a setting when you compare ductus venosus to computerized CTG to settings without computerized CTG. And the reason for this is built within the study was a safety net. The safety net accounted for 33% of deliveries in the late ductus venosus group that included cutoffs of short-term variability that are impossible to identify with visually inspected cardiotocography. In other words, that the Truffle trial was set up with this safety net that accounted for significant number of deliveries in these groups that you cannot see by visually inspecting the fetal heart rate monitor, as is commonly practiced in the United States. Most hospitals in the United States do not use computerized CTG for inpatient fetal surveillance. So taking that information, and it's really important in how you devise guidelines based on this. So guidelines recommendations should be applicable to existing practice patterns. And when you look, for instance, in this paper that was published in the White Journal in UOG, from the authors of the Truffle trial, it was an editorial about the results of the Truffle study. When they were asked, my hospital does not use computerized CTG, can I use normal CTG? And the answer says, we do not recommend this. And when you look at another question in this document related to the safety net, the safety net applied to all patients. Hence, if the results of this trial are implemented in guidelines or local protocols, the safety net criteria should be an integral part. So you can't extrapolate the results of the Truffle trial without having a safety net criteria that existed in that study. Also, I would like to add that the ductus venosus, unlike the umbilical artery, could be abnormal with absent or reversed A wave from cardiac, vascular, or genetic abnormalities in the absence of placental disease or fetal hypoxemia. So in settings where the expertise to use ductus venosus is not available or it's not robust, you can inadvertently making a clinical delivery decision of a premature fetus in the setting that lack Doppler expertise. And remember, these decisions of the ductus venosus is really useful at less than 32 weeks. the ductus venosus has no value in clinical management beyond 32 weeks. So you're looking at a fetus at 26, 27 weeks, and you're making decisions for delivery. If you're making it based on the ductus venosus in a setting in the United States without computerized CTG, the results of the truffle trial may not really apply, and we don't have enough data to make these recommendations. Now, how really important is the ductus venosus in management of early fetal growth restriction? I'm going to tell you it's a rare event clinically. We have vast experience in managing fetal growth restriction in my unit, and we rarely see a pregnancy with reversed flow, absent or reversed flow in the ductus venosus. If you look collectively at all cases of fetal growth restriction, as we define them in the United States, less than the 10th percentile, there's a small proportion of this, maybe less than 20%, that will show you absent or reversed end-diastolic velocity in the umbilical artery during your management, prospectively during your management. And of those cases, only about 10 to 15% will end up having absent or reversed flow in the ductus venosus. So of all cases of fetal growth restriction, the ductus venosus abnormality accounts for a very small proportion of the population that we managed with this disease. And if you look at the truffle study, and if you look at the group that were allocated to ductus venosus without an A wave, absent or reverse A wave, how many of them you think were delivered because of this indication? Only about 10%. The rest were delivered because of maternal hypertension that complicated fetal growth restriction, presence of repetitive late deceleration, the safety net criteria as I indicated before, or they reach the gestational age where delivery is indicated for absent or reversed ductus absent or reversed diastolic flow in the umbilical artery. So overall, ductus venosus account for a very small proportion of pregnancies for management in fetal growth restriction. So if you look at the role of ductus venosus in early fetal growth restriction, remember I said ductus venosus has really no role in management of late fetal growth restriction. The contribution is quite limited, and the evidence from the truffle trial cannot be extrapolated to clinical settings that do not use computerized CTG. And the ductus venosus is technically challenging. Abnormalities may result from pathways outside of fetal hypoxemia, inadvertently delivering a pregnancy early because of assuming that there is complicated fetal hypoxemia in that setting. So this is why we recommended not to use the ductus venosus in the guidelines, in the national guidelines for fetal growth restriction. However, I will add this, that understanding its limitations, if an MFM practice wishes to incorporate ductus venosus in clinical management, I think you can consider this. I would recommend that this should be restricted to the window between 26 and 32 weeks. That's where the ductus venosus is really valuable. And in the setting of absent or reversed diastolic flow in the umbilical artery. Also understanding the limitations that could exist from cardiac abnormalities, vascular abnormalities in the liver, and so forth. How about the biophysical profile? We had a statement that reads as such: further studies are required to prove the usefulness of biophysical profile, and that is really most applicable to early severe fetal growth restriction. This was a very controversial point also, and there was another article with a lot of authors that was published in AJOG trying to rebut this recommendation. First, if you look at the Cochrane library and looking at the role of biophysical profile versus conventional fetal monitoring in addressing perinatal death, you will see that there's no outcome, there's no benefit in high-risk pregnancy. But that the same setting really applies, in fairness, to the non-stress test that we use very commonly. If you look at the progressive change in the parameters, in the testing parameters that we use in the management of fetal growth restriction, looking at the umbilical artery, the presence of absent or reversed end-diastolic velocity, the MCA Doppler above the 95th percentile cutoff, the ductus venosus that I discussed, and the biophysical profile in pregnancies in early severe fetal growth restriction days before delivery. You see that the tests that we use commonly are abnormal, start to become abnormal several days before delivery. And you can see here percent abnormal. But look at the biophysical profile. The biophysical, and this is a study from Dr. Bashat's team. Biophysical profile is normal until about a day to 2 days before delivery. And there's quick, significant deterioration. And the definition is here less than 6, biophysical profile less than 6 in a week before delivery. And if you look physiologically, the reason for this is there are early changes that happen in if you look prospectively on pregnancies with fetal growth restriction until fetal death, that include the umbilical artery Doppler and the redistribution and so forth. But the biophysical profile is a very late manifestation. Loss of breathing, movement, and tone is very late. And in this review, Ahmed concluded that in fetal growth by IUGR fetuses, the biophysical score deteriorates late and often rapidly, making it unsuitable for the prediction of stillbirth unless daily testing is performed. Now, part of the reason for this, these are very important and strong parameters of fetal well-being, right? Breathing, movement, and tone. But the categorical determination on the biophysical profile of either present or absent biases the utility of the biophysical profile in the setting of fetal growth restriction. There are studies that I did not include in my presentation here because of the time limit that were done several years ago in Kipros's lab that actually measured the percent decrease in breathing, movement, and tone over a 24 to 48 hour period and noted significant contribution of those tests to the evaluation of a high-risk pregnancy. The categorical determination that you have to wait until absence of breathing, movement, and tone to get an abnormal biophysical profile is a very severe deterioration. It's a very sick fetus that does not move, breathe, and have no tone. And this is why we see those results. And this is really presented very nicely in this study from Dr. Mari's team when he was in Tennessee, looking at the biophysical profile in the treatment of IUGR who weigh less than 1,000 grams. And they had 48 fetuses at average gestational age of 27 weeks, and here's the average weight. And what they did is they looked at the biophysical profile performed 24 hours of delivery. This is the reason why these pregnancies were delivered. Non-reassuring fetal testing in about a half, IUFD in 7, preeclampsia and others, as you see right here. And if you look at this table, you will see that a biophysical profile of 6 was noted 24 hours before delivery in 13 out of 48 pregnancies, and a biophysical profile of 8 was noted in more than half of those pregnancies. And remember, those all delivered within 24 hours of this test. And if you look at the presence of acidemia, IUFD was present in 3 out of 27 and 3 out of 13 with a day of normal testing. And acidemia, if you look at the biophysical profile of 8, acidemia was present in about half of those pregnancies or so, despite the presence of a biophysical profile of 8 out of 8 in those settings. It is because of this data that we are cautious about the use of biophysical profile in severe early onset fetal growth restriction. And if you see here, their conclusions, biophysical profile alone is not a reliable test in the treatment of preterm IUGR because of high false positive and negative results. The common notion of a good BPP providing reassurance for at least 24 hours is not applicable in severely preterm fetal growth restriction who weigh less than 1,000 grams. If you look at the national guidelines that exist today in the UK, and this is the UK NICE guidelines, you'll see that their recommendations with an A level of evidence is that the biophysical profile should not be used for fetal surveillance in preterm SGA fetuses. And if you look at the Irish guidelines that exist today, there is some caution regarding that. It's also important to recognize the limitations of the biophysical profile to inform fetal well-being in preterm fetal growth restriction fetuses. And the French guidelines also do not mention the biophysical profile as one of the diagnostic criteria or management criteria in fetal growth restriction. So with regards to early onset fetal growth restriction, we did not provide recommendations not to use it, but we provided some caution about the existing data, especially in the early preterm fetal growth restriction. If you're using a non-stress test and if you're doing a modified biophysical profile plus an umbilical artery Doppler, I think that would suffice in managing those patients because you'll have the fetal heart rate tracing per se, but you got to be cautious about using just the pure biophysical profile in the early preterm fetal growth restriction because of the evidence that exists today. So if you have a non-reactive NST as part of the biophysical profile, I think if you have because of the high false positive rate of NST in those settings, then you can go to a full-time biophysical profile or repeat the non-stress test in that setting. But be careful about the evidence that exists today, especially in those very young, very small fetuses that are severely growth restricted. So hopefully I showed you the evidence behind the SMFM fetal growth restriction guidelines recommendations. And clearly, as the evidence evolves, and there's a lot of evidence that is coming out on a regular basis, the guidelines will be updated to reflect the best evidence. And again, I want to highlight that these guidelines were written understanding what is the most common practice pattern in the United States and written to reflect the existing practice pattern in the United States. So thank you very much. I'm going to stop sharing and answer any questions that you may have.
Dr. Abuhamad, thank you so much for that excellent talk. Are there any questions? Yes, Dr. Sharma.
Hi, Dr. Abuhamad. Thank you for this amazing talk. I am Ruchira Sharma, one of the junior MFM faculty members. What's your, my question is about like very early FGR babies, like right at the time of anatomic survey. If you see less than the 10th percentile, or of course confirm the dating, which is the major issue there in a lot of patients, but what would you recommend for those patients? Like how anxious should we make them? Because many times I see when they come back for the 24-week scan, there is a catch-up growth that happens and they're no longer FGR. So when should we bring them back, especially with the threshold of viability now coming more and more down? Like now our NICU can resuscitate even a 22-week baby. So then how would you recommend in terms of like Doppler surveillance? When should we start that? And how should we follow them?
Great, very good question. So in general, I would recommend that the Doppler surveillance and the testing should await viability as it's defined in your institution. So we start doing Dopplers at 22 weeks when there is early fetal growth restriction. What I will do in a pregnancy like this, certainly a detailed second trimester ultrasound looking for associated abnormalities or any markers of genetics. I will counsel them with regards to genetic testing. If need be, there is a higher association with early severe fetal growth restriction with genetic abnormalities, especially with CGH. I will look at markers of CMV abnormalities in those testing and maybe do a torch titers on mom. If she opts for an amniocentesis, then certainly do testing on the fluid. And I will follow them up. I will follow them up in 2 to 3 weeks until they get to viability. If they have severe early onset, I may bring them sooner because they have a higher risk of IUFD if they are very well tested and want to see that sooner than later. But there's no reason to see them weekly before you reach the time of viability in your setting. And what does that mean? Like if you have a 23-weeker with a severe fetal growth restriction, again, it's not the gestational age here anymore. We had meetings with our neonatology team here to define what would be a weight criteria in the setting of fetal growth restriction that they will intervene for. And that is when we decide to start testing. And it's somewhere between 450 grams here based on the feedback that we got from our neonatology colleagues. So I think look at the ultrasound, look at genetics, look at infections because they're higher in that category. And then I'll just bring them back for a follow-up ultrasound to assess what happens.
I see that Dr. Siegel has his hand up.
Thank you very much. It was a great talk. I just had a question almost on your last slide about the early fetal growth restriction before 32 weeks with less than 1,000 grams. It said you do an NST, modified biophysical profile, plus Dopplers, and then if the NST, which has false positives, you go back to the biophysical. But wasn't the beginning part of the slide saying that biophysical wasn't good?
So let me clarify here in that testing. What I was trying to address in that setting is that if you do a biophysical profile in those early fetal growth restriction, make sure that you have an NST tracing in there. And what you're looking in the NST tracing really, especially in the presence of severe early onset fetal growth restriction, not about the beat-to-beat variability anymore in that setting. Really, we're looking at about spontaneous decelerations that will indicate delivery. So if you are relying on a biophysical profile, I just wanted to convey the message that part of that don't use a biophysical profile without a tracing, because that could really give you the high false positive and negatives as I shared the study that Dr. Mari had provided. Here, what I was conveying is in your evaluation, you should have a tracing as part of your fetal surveillance in addition to the umbilical artery Doppler in those severe early onset. Maybe it was the information maybe was misguided the way it's presented, but that's the implication of the slide.
Thank you.
I see that Dr. Brandt has his hand up.
Hi, good morning, and thank you for this great talk. I have a question about the AC less than the 10th percentile cutoff. Classically, we think of using, when we use the EFW less than the 10th percentile cutoff, that probably 2/3 of those babies are constitutionally small and not at risk for stillbirth. And we know there are real risks with false positive testing, with our surveillance leading to interventions on labor and delivery, and maybe even delivery, that preterm gestations or C-sections. So I guess my question is, what's the impact of using an AC less than the 10th on the prevalence of growth restriction and its impact on our patients?
Yeah, so very great question. Thank you. I'm going to answer it for the beginning, and I'm going to answer it for the end of the pregnancy, what to do with an AC less than the third. So for the beginning, there's robust evidence that shows that in prediction of SGA and growth restriction after birth and composite neonatal morbidity, that the AC less than the third and the AC less than the 10th perform, if not equally, better than the estimated fetal weight less than a 10th. So this is why we included it as an added definition in that setting. It accounts for about 16 to 17% additional diagnoses. So you will add about 16 to 17% more pregnancies into your fetal surveillance pool if you do this. So that will add, testing, that will add utilization, as you know. If you rely on the Delphi definition, you will add uterine artery Doppler probably once at diagnosis, MCA Doppler at every level, and follow-up growth, scans looking at growth velocities in the third trimester. The role of AC less than the third percentile for delivery, I get this question very often. I have an AC less than the third, but the estimated fetal weight is between 4 and 9. Do I deliver this pregnancy early as the recommendations exist today for estimated fetal weight less than the third? We don't have enough data on this. This is why it was not included. Remember, the guidelines are now 3 years old, almost 4 years from the time we wrote them. We have a paper that we just submitted for publication where we looked at our pregnancies here, retrospective, and compared AC less than the third percentile with those that have the AC growth restricted by definition, but AC between 4 and 9%. Clearly, there is an increase in composite neonatal morbidity in those pregnancies. It is not to the level of an estimated fetal weight less than the third percentile, but it is about 30 to 40% of those pregnancies will have composite neonatal morbidity afterwards. So there is an evidence that shows that an isolated AC less than the third with an estimated fetal weight between the 4 and the 9th adds morbidity to this pregnancy. Is the level sufficient enough to deliver at 37 weeks, or could you push it a bit further, 38, 39 weeks? We don't have this evidence yet. But certainly we will show that there is increased morbidity in those pregnancies. I don't know if I answered your question. I tried to answer it on both ends because it's a very common question. What do I do when the AC alone is less than the third and the estimated fetal weight is less than the 10th, but it's not severe? We, in our lab, we still use an AC less than a third to recommend delivery at 37 weeks.
We're just not getting better at identifying the pathologically small fetuses. And we have extended the group of patients who we're considering at risk. So I think we're just going to have more false positive testing, and patients are going to be referred to labor and delivery for more interventions. So that's just my concern. But I thank you for your presentation and for your leadership in this space.
I see that Dr. Lin has her hand up.
Hi, I'm Ruby. I'm a first-year MFM fellow. All the data that you showed us is for singleton pregnancies. I was wondering for di-di twins, do you use the same delivery timing guidelines for di-di twins?
No, very good question. This is all for singleton pregnancies and by design, because di-di twins will have much more variables that come into the decision processes. Certainly, you will push the delivery sooner than you would for singleton pregnancy. We don't have evidence really to guide with regards to all these different parameters that I discussed in singleton pregnancies. But because almost all will deliver by 38 weeks, so your starting point is lower, so you will push the delivery sooner. If you have one fetus in a di-di twins that have, absent end diastolic velocity, probably delivering at 32 weeks would be optimal, if not a bit, given the window between 30 to 32 weeks that we provided in this guideline versus the previous one. The previous one was 32 weeks for absent, for reversed, and 34 weeks for absent. We gave a window today because based on the evidence that evolved, the risk of IUFD in those settings really is equivalent to when you reach gestational age of 30 to 32 weeks. So in pregnancies with twins, I would push that a bit sooner, given the increased risk of morbidity and mortality in that setting. So for instance, if you're delivering now for reverse end diastolic velocity at 32 weeks, I would probably deliver a twin at 30 weeks with one of the fetuses and di-di with reverse end diastolic velocity, and so forth. You just push it a bit sooner, but there's no evidence, Ruby, there's no evidence to guideline to provide really strong recommendations relating to that.
Thank you.
There is a question typed into the chat that says, what is the earliest gestational age that you begin applying the NST for surveillance?
So when pregnancies are admitted to the hospital for management, well, let me answer this twice in different parameters. In early onset fetal growth restriction, especially in the severe prematurity time window, I'm going to say from viability, let's say 500 grams. That's more commonly used in Europe. 500 grams and onward. We're doing the non-stress test, just looking for spontaneous decelerations. That is what the use of the biophysical of the non-stress test is. So we're starting testing twice weekly in those settings, and we're looking at spontaneous decelerations on the non-stress test. When they are admitted to the hospital, typically when there's absent, and certainly when there's reversed end diastolic velocity in the umbilical artery, Then with reversed end-diastolic velocity in the umbilical artery, we're doing testing sometimes twice, if not 3 times per day. And we're looking at spontaneous decelerations in that setting. We are not looking at the variability and trying to create criteria for NST. That's how we use the fetal heart rate tracing in this category of severe early onset. In the late fetal growth restriction, then use the classic criteria for non-reassuring fetal heart rate tracing.
All right. We have one more question from Dr. Rosen.
Dr. Abuhamad, thank you so much for speaking.
Thank you.
Interestingly, I'm so glad people are asking questions because I could have asked 20 minutes of questions at the end of your talk. I just want to make one or two comments, and then I have one question for you. One is a number of years ago, I was very interested in IHR. I even made a concept presentation to the MFMU, which was kind of dead on arrival because they didn't like to do ultrasound conferences
And Dopplers,
ultrasound studies.
Yeah.
But when I really looked at the truffle study, I thought that study was, in order to increase enrollment, I think they made a pretty big mistake by enrolling patients who already had a diagnosis of preeclampsia. They didn't exclude those patients. Some of the patients with only IHR went on to develop preeclampsia later, as expected. But I think that really altered the results of the trial and made the applicability of those results less useful. I think it's interesting that you argued against using MCA Dopplers as the basis of delivery. I have this old monograph by Harrington and Campbell. It's I know it's pre-2000. I got it when I was a fellow. I'm not sure if you've seen it. It's like a pink book. It's really thin. I lend it to my fellows and threaten them. If they don't give it back to me, I'm going to find them and hunt them down. But they actually, their data show that MCA changes happen early. It's a predictable early change with growth restriction due to placental insufficiency. So not surprising, it doesn't give us a lot of information about fetal health and when to deliver them. My question is, has there been an application of artificial intelligence to put all of the parameters you've discussed today together, including estimated fetal weight, multiple Doppler studies, CTG, biophysical profile, maternal characteristics, including presence or absence of preeclampsia or a rise in blood pressure? Has that, I'm guessing that's been done. I don't know the current literature, but has that shown any promise?
So not that I can recall off the top of my hand. That I think it would potentially have. You're thinking about prediction, right? A prediction model at the time of pregnancy, or a prediction at the time of initial diagnosis.
Well, at the time of the initial diagnosis, and then as you track through the pregnancy, there'll be a clear indication about when you should deliver. That's the $1 million question: is the baby safer off in uterus or out? Just Dr. Abuhamad, one more comment. When I made that presentation at the MFMU, what was really funny was that I got two criticisms for my presentation. One of the big ones was that we all know what to do already. This is 2007 maybe. And they all said, why are you even presenting this? We all know how to manage IUGR. We're really good at it. And when I did a survey to try to come back at them saying, I don't think you're doing the same things, all 14 MFMU centers were doing something entirely different. Some were using contraction stress tests. Some of them were using Dopplers, but didn't rely on them. Actually, if I could ask a more important question, has your guideline that you put out, do you think that has standardized management more across the country? And do you have any feedback, or have you studied that? I'm really curious about whether approaching it more uniformly.
So let me address the first question first, because that's really important in prediction. And this is, could we predict which pregnancy is going to deteriorate? And could we predict which pregnancy could not? Because that's really critical for the utility of testing and how overuse of testing we do. My third-year fellow, Dr. Waller, who's graduating this year and staying with us, her main thesis was following a large number prospectively of fetal growth restriction and looking at maternal cardiac, some parameters from maternal heart, ophthalmic artery in the mother, some bio testing on some of the placental factors, and Doppler parameters in predicting a large cohort of second trimester fetal growth restriction into the third trimester. She's looking at her data now And I think she has about 50 pregnancies with severe early onset fetal growth restriction. So we will have some robust data to indicate about what is a predictive parameter and which pregnancies are going to deteriorate, which pregnancies are going to have preeclampsia, which will not. So that I think will be really important. I believe that the guidelines have provided some standardization in the United States because, as you know, there was a lot of gaps in how we manage fetal growth restriction, and bringing everybody together with these big parameters, use this, don't use that, I think has been adopted. I don't have any data to show that, but at least based on the feedback that I get and the calls that I get routinely, I think a lot of practices have looked at them very carefully, if at all, and altered their internal protocols based on those, whether they did some modifications to them or not. But I have a sense that it helped to standardize what we do in the US. And that's really the purpose of the guidelines. And I think, as you know, having a guideline for management has significantly impacted outcome, positively impacted outcome in many diseases, especially in growth restriction.
Thank you.
All right. Thank you. Thank you so much for this excellent talk, Doctor.
Thank you. Thank you for the invitation. Take care. Bye-bye.
Yes, it's been wonderful having you, but we have to end it here, and I wish everyone a good day. Thank you.
Thanks. Bye-bye.